Hey guys, the case that I've chosen to reflect on involved us attending a 46-year-old female at a doctor's surgery. She was complaining of sudden onset crushing central chest pain upon nil exacerbation. She'd been sitting at her desk at work and had started to experience symptoms, after which she got a colleague to drive her to her GP. On arrival, she was hypertensive at 170 systolic, tachycardic at 140, tachypneic, pale, diaphoretic, nauseous, really distressed, quite upset. The 12-lead ECG that the doctor had performed showed minor ischemic changes that include some T-wave elevation and borderline ST elevation, which was mirrored in the 12-lead ECG we performed with our own monitor. We immediately commenced treatment with GTN, cannulated her and administered analgesia and an antiemetic. We didn't give her aspirin as the GP had already administered it prior to her arrival. We then loaded her and expedited transport to the Princess Alexandra after pre-notifying them, as we felt this was a more appropriate facility to transport to, given her chief complaint. En route, her 12-lead ECG actually started showing a few more alarming changes, with RSR patterning in leads V1, V2, some S-wave slurring in lead V5 and V6, I think, and slight broadening of the QRS complex. And the ST elevation was more pronounced, as was T-wave elevation. So we were sort of led to believe that, sort of starting to suspect right bundle branch block with ischemic changes. So we notified the PA of these changes as they cropped up, and we transported and handed over the patient without any further incident. The case was a little overwhelming for me at first. I feel that some of that came from my inexperience and no doubt over my ability to sort of handle this subset of patient and my ability to interpret an ECG. My mentors were happy for me to be primary care on this particular case though, so I found that really assuring, and it gave me confidence when I was asking the questions. I hit a bit of a wall though when looking over the ECG the doc had printed off, but my mentors really got me to break it down to the basics and tell me to back myself, again, which really sort of helped. I felt a little bit out of my depth sort of putting the two and two together, but I was pretty stoked when my mentors agreed with the conclusion that I'd come up with. I think the biggest thing I realised is that I really do need to work on my 12-lead ECGs a little more so that I can identify and interpret the significance of what I'm seeing in a more accurate, effective and timely manner. This case was really cool, one to go to as a learning experience also for a number of reasons. Firstly, the age and appearance of the patient really threw me for a bit there, as she wasn't the stereotypical AMI patient. She was relatively young, slim build, very fit and healthy, so it made me really reevaluate the potential I have as a practitioner to pigeonhole patients, if you will. I've always been a big believer of the treat the patient, not the monitor sort of school of thought, but I didn't realise that can actually be potentially harmful if I apply that principle a little abstractly and start allowing sort of these preconceived notions to get in the way of properly assessing and diagnosing, if that makes sense. So in my mind, I've now modified the principle to treat the symptoms the patient is exhibiting, not the monitor. It also highlighted for me the importance of really understanding all the basic components of an ECG. When we debriefed after, I found myself really referring back to those basics to help me understand exactly what was going on in her heart and therefore the corresponding ECG changes we were seeing. This case also helped me reinforce the importance of calming your patient and the physiological benefits of this. So as I mentioned, she was very distressed. She was crying. She's saying she felt like she was going to die. And just by talking to her and reassuring her that, we were taking the best care of her and, that, she was in safe hands, we could see her heart rate decrease a little, her breathing would settle, she'd become a lot more calmer. And, it was actually quite cool seeing those benefits firsthand. So there were actually a few really important lessons I took away from this particular case. Firstly, that there is always potential for tunnel vision or pigeonholing your patients, and that sometimes that requires constant vigilance on behalf of the practitioner to ensure you're getting the whole picture. It also really highlighted the importance of having thorough underlying understanding of ECGs, so really knowing your basics of what you're seeing and the significance of this and how this can give you confidence with your diagnostic and treatment capabilities as a practitioner. It also really helped me to understand that as practitioners, we can easily forget how important we are as people within the treatment process, that we as people and the way we communicate are pretty potent therapeutic tools and have the means to contribute meaningfully toward treatment. This also includes the impact of patient education we provide, as it's coming from a position of authority. So when she was a little settled and all of our treatments were up to date, we took the time to carefully explain that she should have called 000 instead, as opposed to going to her GP, that time is muscle, and that she promised us that she would ask if this would happen again, that she would do this if this happened again. I feel that picking that moment as paramedics to educate her about this will be a lesson that she'll take on board a lot more effectively, and hopefully it will be of use to her in the future, or to someone that she loves and cares about. Or we just created another hypochondriac, either or. That's about it.